Hi, my name is Dr. Baldeep Singh, and I'm an internist here at Stanford. And today we're going to talk about the physical exam and the differential diagnosis as it relates to pain in the hip region. Next, we're going to ask the patient where the pain is using the finger rule, asking the patient to use their finger to describe where the pain is, focusing on three key areas: the anterior area, the lateral area, and the posterior area. Steve is here to help us with our demonstration today, and we're going to show you that again by demonstrating here again, having the patient focus. Is the pain here in the anterior area in the front of the leg, the lateral aspect or side of the leg, or the posterior area or back of the leg? It is really helpful to organize this pain into three locations: anterior, lateral, and posterior. Anterior. True anterior hip pain suggests pain within the hip joint. This includes many diagnoses such as osteoarthritis, neck fracture, acute or septic arthritis, femoral acetabular syndrome, and avascular necrosis. Meralgia paresthetica presents with a superficial burning in the upper outer thigh and is sometimes initially confused with thigh pain. Lateral. The differential for lateral hip pain includes greater trochanteric bursitis and external snapping hip. By far, greater trochanteric bursitis is the most common diagnosis with lateral pain. Posterior. Posterior pain includes radiculopathy radiating to the hip, sacroiliac joint pathology, and piriformis syndrome. Next, I'll demonstrate how to perform the examination for these diagnoses. Starting with the anterior hip, we're going to focus on a few key tests to help us differentiate if the pain is identified in the anterior region. Starting with the log rolling test. The log rolling test is quite helpful if we suspect a hip fracture, whereby if the patient is recumbent in the bed, we can move the leg or roll the leg like a log back and forth, trying to elicit pain at the hip area. We can further confirm that with the compression test, first by having the patient fully extend the leg and hitting down the leg, the length of the leg, tapping on the knee, again also causing discomfort if there is a fracture at the hip anteriorly, and finally laterally. If that is all negative and we're convinced that there is no hip fracture, then we will proceed with range of motion, whereby we put the patient's leg in full extension here, where we're going to, at a 45-degree angle, externally and internally rotate the leg to about 45 degrees. If we see severe limitation, that is very suggestive of pathology within the joint itself, such as seen in osteoarthritis. Finally, we conclude by putting the patient in the extremes of range of motion. If the patient elicits pain with this provocative test, it is very suggestive of a labral injury. Finally, if the patient complains more of thigh pain, it may suggest a diagnosis of meralgia paresthetica, in which case the patient will have burning across the top of the thigh, and on exam will have demonstrated decreased sensation. Next, we move the patient to the lateral side in this position to assess for pain on the lateral aspect of their hip. There are a couple things we'd like to focus on. One is greater trochanteric bursitis, where the patient will have pain over the greater trochanteric area. So by palpating on this area directly, if you're able to elicit pain, it is very suggestive of this diagnosis. Next, we want to look at the diagnosis of snapping hip, where the IB tendon may be causing pain as it snaps back and forth over the greater trochanteric area. To do that, you'll grab the entire leg and move it back and forth, flexion and extension, looking for a popping or pain elicited at this site, thereby confirming the diagnosis of a snapping hip. Finally, we end on posterior pain. One of the chief causes of posterior hip pain is lumbar radiculopathy. We'd like to refer you to our Stanford 25 video on low back pain for that portion of the exam. Next, we'd like to focus on the possibility of pain at the SI joint or sacroiliac joint. To do that, we do what's called the Faber test. Faber actually stands for flexion, abduction, and external rotation. Once the patient is in this position, we place pressure over the knee and try to elicit pain in the posterior area. Finally, we'd like to focus on another diagnosis, which is piriformis syndrome. The piriformis muscle is at the top of the buttock, and can sometimes compress the sciatic nerve, thereby causing posterior buttock pain or hip pain, or also can simulate radiculopathy, as we've seen in our low back videos. To elicit this, we will try to do two provocative tests to help us. One is we can fully flex the leg all the way up to about 90 degrees. At that point, if the piriformis is fully activated, it may cause symptoms in the buttock area. Then, if there's any pain in this area, we may want to bend the knee and put the knee across the body of the patient, holding the hip in place to try to stretch that piriformis muscle and fully compress the sciatic nerve. If that elicits pain, it can be very suggestive of piriformis syndrome. This concludes our video on the approach to hip pain. I would like to thank Steve for helping us with the demonstration today. For further videos on other parts of the exam, go to our Stanford 25 website.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.